لا إله إلا الله لا إله إلا الله لا إله إلا الله ما لنا رب سواه.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah wa salatu wa salamu ala rasulillah wa sahbihi wa man wala. Just so glad to be here. So happy, I got here. I wanted to attend all the sessions and just be inspired from the speakers yesterday, today, the wonderful banquet, and kind of be part of the experience. So definitely want to thank the organizers for their work in doing this. You all for taking time to attend. I think talking about time, Dr. Awad was talking about making time in your schedule to do things that are important to you and as part of your identity to make sure that you're part of a network as such. So my discussion really today is going to be the proverbial question I always get is, what is an FQHC? Why is it important? Why is UMMA one? Why are there free clinics? What are the other models out there? So a little bit of context of what a federally qualified health center is, and then kind of going into UMMA's model of care, how we provide care to the community and opportunities as you choose your career paths and going into primary care or even other specialties, and how you can interface with FQHCs either as a full-time staff member, or I think building on some of the discussion that was happening yesterday from the gentleman from ISPU about serving on the board of a federally qualified health center and the expertise you can bring even being a practicing physician and not working at an FQHC. And so how many of you are familiar with what a federally qualified health center is, just by show of hands? Just curious. Okay, so a few of you. So just to set the context, the federally qualified health centers really started with the Lyndon Johnson administration as an effort on the war on poverty. And as Medicaid started rolling out, rural healthcare in urban areas were not being addressed. And so the war on poverty under the Johnson administration started kind of the modern day health center movement as we know it. And so this is a little bit of kind of the timeline in the early 1960s. It did start as part of the civil rights movement. A lot of community organizers are on the ground and really understanding the needs of the community and addressing it in a holistic way. And so it started off with the Migrant Health Act. Then you can kind of see how the timeline has evolved into the modern day kind of setup of the community health center system under the Healthcare Centers Consolidation Act as well. As towards the end of kind of the introduction slides, I'll go into how do you maybe become a federally qualified health center, how you can support your communities if they'd like to go down that path, or if you'd like to stay a free clinic and are involved in free clinics, that's also a path to go down as well. And there's certain advantages there as well. So currently there are 1,400 community health centers in the United States. This map looks like that because obviously every community health center has multiple locations. So throughout the United States, they're spread out. I guarantee you there's one in your local community. And I think the fundamental aspect of being a community health center is that they're community-based, they're patient-directed, and I'll get into that in a bit. They're oftentimes, they have to be for the most part, nonprofit organizations if they're standalone entities. There are some hospitals that run federally qualified health centers on the side as well. And again, some other critical areas is comprehensive, culturally competent, high quality primary care services in the communities. And so there are rural health centers, there are urban health centers, there are centers that focus on, for example, migrant work, or some that might be doing some work on homeless outreach services. And so there's a breadth and kind of depth of making sure that the safety net in this country is being taken care of. We talked a little bit about yesterday about working in the system versus outside the system. And I think if you want to really make a significant impact, a federally qualified health center is an excellent way of both working inside and outside the system, because one, we're providing direct services, but then you're also challenging the status quo, and I'll share with our care delivery model about how really we're going upstream to make sure that care is being given to patients in a culturally competent way. So again, in general, community health centers are mission driven, right? Quality services. And I think some of the cornerstones that we talked about are community health centers are independent, nonprofit, public community-based institutions, high quality healthcare as well, open to all regardless of insurance status or ability to pay. UMMA's patient population currently is about 30% uninsured. Different counties have different programs, and obviously depending on which state you're in, whether or not you had Medicaid expansion take place, you have community health centers who have the safety net, right? So if you're in a state that did not have Medicaid expansion or have people who are significantly uninsured or underinsured, where do they go if they're not going to the ER? They're going to a local community health center. So we really are the safety net as well. And one of the interesting aspects of a federally qualified health center, and it's true for UMMA as well, that at least 51% of our board of directors are the patients that we serve directly. They're the ones there holding myself accountable. So my bosses are the patients that we serve, majority of them. And that really ensures a few things. One, that quality healthcare is being delivered, because who's best to talk about their care, not only in the four walls that they need, but also in the community than community members themselves. And who best to advocate on your behalf in terms of a holistic in the community about the services they need than community members themselves. So currently, federally qualified health centers serve nearly 30 million people in the United States. So every 1 in 11 people in the United States is served by a federally qualified health center. And it just, for example, you might be in a transition in between a job. You don't qualify for certain services. Where do you go? You get Medicaid. So if you have Medicaid, oftentimes you're going to be served by a federally qualified health center. That's 1 in every 8 children in the United States attends a federally qualified health center. 1 in 5 in rural communities. Close to 400,000 veterans. I'll talk a little bit later about school-based health services, because one of the clinics that UMMA runs is actually on the campus of a high school in South Los Angeles. 1 in 3 of the patients that come to federally qualified health centers lives in poverty. 1 in 5 are Medicaid recipients. Agricultural workers, these are the farm workers who are at the backbone of our entire food system in the United States, are being served by community health centers. And 1.4 million homeless individuals are served by community health centers. So what are the benefits, and well, how do we sustain ourselves? And as you may know, in a hospital setting or a private setting, no one wants to see, Medicaid or even some Medicare patients as well. And so we have something called a prospective payment system methodology. Won't bore you into the details, but we are able to get a little bit more of an enhanced rate because we're serving some of the most underserved communities in the United States, and that helps us to sustain our operations, but also do some other programmatic work as well. We have access to favorable drug pricing under something called the Section 340B of the Healthcare Administration Act, where patients can get low to no cost medications. And what we do is actually reap the benefits from the pharmaceutical companies who have to create a pool of funding to make sure that underserved communities are being affected. That program is actually under threat right now, where a lot of big pharmaceutical companies want to take some of those benefits back and keep them for their own profits. An area I don't have time to get into, but I did tell the organizers, if you want to do a webinar and I can kind of go into specifics, ask someone from the Bureau of Primary Healthcare to join. But if you haven't looked into it, look into National Health Service Corps. They have loan repayment options. They have a varied 3 loan repayment options and kind of service payback down up to every year $150,000 of loan forgiveness for every year you work at one of the sites that are served by federally qualified health centers. So there's an application process. You have to find a site. You have to make sure the site has it's called the AMMSA score. 25 is the highest need, and then it kind of goes all the way down to 12 or 13. UMMA's AMMSA score for primary health care is 21 out of 25. For dental and behavioral health, it's 25, one of the highest needs communities. And many of the providers that we have on staff are part of the loan forgiveness program as well. Access to federal vaccines program for children as well. So kind of what are the 4 pillars, kind of to put into some as we're kind of drawing down in terms of the introduction here. Federally qualified health centers have to serve a medically underserved community, provide comprehensive primary and preventative care, again, governance, community-based board of directors, and payment-wise, all patients regardless of their ability to pay. I won't get into specific details, but I think as a nonprofit organization, as a health center, we have kind of 19 program requirements, and I think it's good for you to know if you'd like to talk to your local, Masjid Free Clinic or other, students that are getting together. Again, UMMA's founding is a group of Muslim medical students, undergraduate students who came together to create UMMA and put it on its path to becoming FQHC. So really kind of, four big areas: the needs, services, management, finance, and governance. So these are the things that HRSA audits us on a very regular basis. We have we have a lot of audits. I would say every month we're probably doing 2 or 3 audits from either a health plan, HRSA, just local county programs. So it's very, very intensive in terms of administrative staff. Alhamdulillah, today we have closer to 85 full-time staff. Half of that are our clinical team. The other half is our administrative team. My executive team is made up of, obviously, myself. I report to the board of directors. I have a chief medical officer as well. I have a chief financial officer, chief dental officer, chief advancement, who does a lot of our community engagement work as well. And that's kind of the core of my team. UMMA's patients, about 99% of our patients are not from the Muslim community. We serve the local South LA community, and about, I would say, 90% of our staff is also not Muslim. And even though they're not Muslim, they choose to come and work at a Muslim organization. And I can get into that a little bit later as well. So again, really one of the emphasis is being placed on having board members who are actual patients of the health center, and that's really important. And this is kind of some of the language that's out there in terms of what it means to be a patient and have face-to-face contact, a documented visit. And so when they come and audit, you can't just say, you know, X so-and-so is just a patient by name. They actually have to receive benefits, and they check records in obviously a HIPAA-compliant way to make sure that they are actually a patient. And for many of you, if you're not a patient, right, we have other community board members. So non-consumer board members are representatives of the community. So there are many folks who originally founded UMMA, went into healthcare as well, but still wanted to participate. And another way to make sure that there's a lack of conflict of interest, especially in terms of board representation, is that no more than 50% of the non-consumer board members that we have can derive more than 10% of their annual income from the healthcare industry. So there's a limitation in terms of making sure there's no quid pro quo and that people are not kind of serving their own self-interest. So really, really an emphasis on community-based and local organizations. So if you're curious about what it takes to become an FQHC, this is kind of the pathway you can follow. One specific details here, but really the designation process in order to become an FQHC requires you to act like a lookalike, as they call, for 2 years. So that basically means that you have to abide by all the federal regulations for roughly 2 years without actually receiving enhanced payments or government contracts and the HRSA kind of HRSA 330 grant program, as they call it, funding. And so if you are interested, if you'd like to open one in your own community, partner with another one, become a lookalike, there's more information that's available on the Bureau of Primary Healthcare's website and the HRSA website as well. But really CMS, at the end of the day, Center for Medicaid Services, designates federally qualified health centers in order to provide these services. Again, currently there are about 1,400 health centers in the United States. Okay, so I think I want to do that primer, and I'll get into the presentation now about what UMMA's work is, because it's really important that you understand that to really understand the integrated model and approach that UMMA has really taken in the community to provide healthcare. Our mission is similar to other healthcare centers across the United States, and the missions that I shared earlier. It's really providing high quality healthcare regardless of ability to pay. And we understand that healthcare in local communities that are underserved is part of a larger network, right, of institutions addressing the health and well-being of the underserved communities. Again, being very mindful of cultural, spiritual, social, and economic realities, right, that impinge upon them, and traditional barriers to accessing care. So early in the 1992s, early 90s, if you recall, there was some significant civil unrest. This goes back to even in the 1960s in Watts and the work that was happening. And I kind of will interplay my story here. I'm not a physician by training. My background is in community organizing. I primarily focused on civil rights and immigrants' rights work earlier in my career, and then got into public policy as well. And I think the health center movement really was a combination of ensuring health equity, which is a cornerstone of people living healthier lives, and it's a primary focus, because if you don't have health and wellness, everything else is focused on getting that up to par for ourselves and our families. And the community organizing aspect of really allowing individuals on the forefront of the ground to dictate what they need for their communities in a system that oftentimes sees them on the outside. And so instead of telling patients what to do, right, it's actually involving them in the conversation. And so that's UMMA's story as well. So when the group of medical students came together and they saw what was happening around them. Many of them at UCLA at the time, Charles Drew as well. Charles Drew is the only historically black serving college on the West Coast. It's in South LA in Inglewood, California, nearby. This is kind of the reality they walked into. And so they came together. This is a picture of some of our founders who are still very involved in the clinic. And they went to the community and they said, you know, we want to provide mobile services and we want to, you know, do small pocket things in the community and, you know, help out. And the community said, you know what, if you really want to help out, we want an establishment and a place of care for ourselves and our families to come to. We're sick and tired of the one-stop mobile things that don't have any transition to care, that we're just really tired of that. So we want a physical location. And at that time, right after the civil unrest, a lot of community reinvestment dollars were being put back into Los Angeles. And the students, the students went to then Councilmember Rita Walters, who was an LA City Councilwoman, and made a pitch to the Councilwoman. Said, you know, we're here, we want to make a difference, we want to make an impact in the community. Is there something that we can do about serving the community? Can you help us? And in that one meeting, she said, if you guys are really serious, the county will give you a building if you're going to make it happen. And they walked out of that meeting with our first clinic location, which looked like this when originally founded. So this is a old rundown childcare facility that the county donated to these students, free of charge. And actually just a few years ago, you know, we paid down that building by seeing X amount of patient visits, and now we have the deed to that building, you know, over 25 years ago when it started. And so they collected equipment, you know, they're using their parents' garages to hold some of their things that are happening for the organization, and they raised over $1.3 million to start. And back then, that's a lot of money, if you can imagine. And that's really where they started the first clinic, and we get into a little bit of what that looks like today. So again, a little bit of the legacy in terms of how UMMA started. Again, started off as a volunteer-run organization in 1996. A lot of the roots in the history, again, started in the early 1990s with the civil unrest. You know, a pivotal moment in 2000 because we were still operating as a free clinic, so not having, you know, the budget we have today and then enhanced rates. And operating a free clinic is very taxing, both in terms of just the management, how much you can do, referrals, other things like that. The Muslim community in Los Angeles came together, said, no, UMMA is really an important institution. We need to help save it. And so they raised $400,000 in one night to help put us on the pathway to becoming a federally qualified health center, which we did in 2008. So, you know, you have the history of what that entails and what that looks like. And then have continued to expand our locations. The first location is our clinic today, what it looks like. And the second one is our school-based health and wellness center, which I'll talk about in a bit as well. In 2015, we expanded to providing comprehensive behavioral health services. Currently, we have 4 licensed clinical social workers on staff that, again, going back to the model that Dr. Awad was talking about, truly integrates care. So our LCSWs are part of our care teams, both with the physician teams and other team members, social workers as well, case managers that help the patient in their entire care as well. One of the interesting things during the pandemic, and as testing and vaccines were very scarce in the community, we really made a concerted effort to make sure that vaccines and testing were available in the community. So at this point, you know, we've done over 16,000 vaccines in South LA. We're the second largest vaccine site for the entire community in South Los Angeles. And that's really because we've built that community trust over the years. And it wasn't just, you know, getting people out there to get vaccinated. There were some difficult conversations about hesitancy of vaccines in Black and brown communities, and really having patients feel comfortable about the vaccines that they're getting, their efficacy, why it's important for them to get vaccinated. And so it kind of became a community space, and I'll have a little picture of that in a bit to show you in terms of what that looked like. So where's UMMA now? We have a 13-member board of directors. Again, 53% of our board is consumer members, diverse ethnic representation, both in terms of staff and board. I make the joke, our chief medical officer is of the Jewish tradition, and she chooses to work at a Muslim organization. And our board chair currently is Protestant. And so we say we have a multi-faith effort going on, but they all understand and they all are invested in an Islamic institution. So what does that go to tell you? It goes to tell you that the framing is changing, right? Where do we go from doing this work in a manner that professionalizes Muslim institutions. Every faith community in the United States plants a certain banner and flag, right? They do food banks, charity work, everything. What's one of the major ways a faith institution in the United States plants that flag? By creating a hospital, by creating a hospital system. And as the Muslim community matures and goes down that path, inshallah, UMMA wants to be at the forefront of making sure that that's possible and capable, and providing a pathway to inspire some of you to take this mantle on of areas that we will definitely fall short on. But that's part of the progress and the way forward. So these are our board of directors, diverse board of directors, both Muslim, not from the Muslim community, again, 53% board members. UMMA's national voice as well. We've had the Surgeon General's office visit a few times, look at our model of care, model of health clinics, and for, again, other clinics around the United States as well. Voice for Health and Social Justice as well. As one of our founders, Masood Khan, was previously invited by President Obama to talk about UMMA's model at the White House. So who are we now? Going into kind of how we provide care today. Over 75% of our staff come from the community that we serve. We were just reflecting on a few years ago. We have, in many families in this case, we have one family who we've served now for over 4 generations. 4 generations of family that we've served, the community of care. So grandparents, the kids, kids, the entire family is being taken care of by UMMA. That's very powerful. And if you're looking at making lasting impact and building those deep relationships, and not just seeing their patient that walks into the hospital and not knowing what happens to them, these are some deep, deep relationships that we built with our patients. So going over a little bit of our patient impact, we did take a significant hit with COVID in terms of the community not wanting to seek care. One of the interesting things that happened with COVID was, up until COVID hit, community health centers were not allowed to provide telehealth services. So if you have a private PCP, you probably were doing in some significant way either telehealth via modalities of phone or video, and that was not available until the pandemic hit. So almost in 2 weeks' time, we had to transition to telehealth, not only in terms of our infrastructure, but again, if you can imagine the needs of the community to access telehealth, and there's automatically this assumption that everyone had access to broadband. And now there is some significant push at the congressional level to make sure broadband is a fundamental right in the United States because of the critical nature of it as well. So some of the visits we've had in behavioral health, primary care, patients in our care have dipped again in the last few years a bit. Telehealth. I'll talk a little bit about our free farmers market that we do in a minute. It's now up to 85 staff members, and again, staff members are from South LA. So who are our patients, right? 42% live below the poverty line. 62% are Medi-Cal, or basically Medicaid. Medi-Cal is for California. 31% uninsured. A relatively younger population, middle-aged, that we serve. 72% Latino and 21% African American. So really a litany of services that we provide on site to our patients. And if we're not able to provide those sites, we have referral arrangements with local organizations, other private practices as well. And again, I think we've really been proud of our behavioral health and wellness service expansion. If you're going into psychiatry, I saw some of you raising your hands. Please, when you're done with your studies, reach out to a federally qualified health center. Psychiatric services are very, very difficult to come by in underserved communities, and there's really a large need. There's roughly 1 physician for every 10,000 patients in South LA, and that number continues to rise. So wanted to take a moment to talk about a bit about our Fremont Wellness Center. This is our second location. It's located on the campus of John C. Fremont High School in South LA. And this really came up with a partnership and collaboration with the Los Angeles Unified School District, second largest district in the United States, Neighborhood Land Trust, to create a space where we can really create and actualize wellness. And so we are located next to a 1-acre community garden that students and the community have access to. And we provide a kind of a plethora of services. We also have something that we're proud of called the Student Health Leader Program. We partner up with the students at John C. Fremont High School on mentorship. There are student ambassadors to their peers about mental health, about primary care services for their families as well. And then they link that care back to us. They are paid student interns that we work with, and so it's really building their capacity to lead in their communities. And many times we hire them to work at UMMA once they finish, if they are going to community college or they're transferring locally to a university as well. This Fremont Wellness Center, I'm trying to see if this Fremont Wellness Center also hosts a food insecurity initiative. And so part of being an FQHC, as you understood, is really being community focused. And we went to the community saying, we're all excited and said, we want to open up 2-3 more clinics in these areas. What do you think? They said, you know what? We need more access to food. We said, like, wait, well, but that's our mandate. So what did we do? We partnered up with LA Food Forward. And so now on a yearly basis, we distribute over 350,000 pounds of fresh produce to over 29,000 families a year. And so that was really an effort that the community told us, we're living, we understand that you're providing care, but outside the 4 walls, we're in a food desert in South LA. Fast food restaurants, grocery stores, probably an additional 3 or 4 grocery stores have closed down in South LA. There's no community investment there, and food insecurity and food deserts are another topic. But that also happened with the partnerships of 21 other nonprofit organizations and city agencies as well. So this program has continued to expand. We recently purchased a food truck that will be going out to other communities and respective communities as well. So again, community engagement. So many FQs do health fairs. They have school-based parent nutritional workshops, local with other PTO organizations as well. There's some other supplemental programs and services, and I think it's unique because if you have a particular interest, and if you go to your local federally qualified health center, you can start programs that serve very specific communities. So there are certain federally qualified health centers that might work on the Bosnian Muslim community or the Somali refugee community or African American community in certain, whatever it may be. But these are programs that can oftentimes be augmented with the services that they're already providing. So we have a particular program called the Black Visions of Wellness program. It's a wonderful program that we work on the county with to provide additional services to community members as well. Flu vaccine programs, mammogram clinics as well in the community. So again, I wanted to talk a little bit about our COVID vaccine efforts. I argue to everyone that we had probably one of the nicest vaccine clinics because it was outside in our 1-acre community garden. And again, 16,000 vaccines. And I think for us, if you remember, there was a vaccine hunt early on. Everyone and anyone was trying to find locations to get vaccinated. And we took one step further. We made sure that the patients registering on our vaccine sites actually had addresses in the community. So that made sure that we had over 96% of our vaccines we were giving actually came from communities of color and underserved communities in South LA. And we went a little bit above and beyond for that, but again, it was about community access and making sure that health equity was actualized. So again, really a COVID-19 response that we had to jump into with active screenings, increased telehealth capacity, outreach phone calls to community member, and overall engagement effort to really show why vaccines are important in the community. This is a big hit for us. I mean, as frontline staff, I wanted to also share, we started a food pantry for our staff, and we provided groceries to our staff members, because many of our staff members, if you remember in the initial days of the pandemic, there was grocery runs and food was getting off the shelves and things were, by the time they got off of work, oftentimes they didn't have the ability to get things for themselves and their families. So we were able to provide those services as well. So really taking care of our staff just as much as we're taking care of our community. So we continue to grow. This is one part of our expansion to create an integrated behavioral health model of care at our Florence clinic. So that's up and coming, that's happening. Really excited to show our new dental clinic. This is what it looks like. It's on the campus of Fremont High School. This will serve the local community and the students on campus as well. The number one reason for absences on the campus of LAUSD is dental care, the need for dental care. And so dental care is really, really critical. And this is what our wellness center, a new dental center looks like. We just opened last month, and so we are operating currently right now. We have 4 dental operatories as well, and we'll be purchasing an additional mobile dental unit to go out and serve the community as well, inshallah. One of the interesting aspects I want to also share, and not on these slides, about Fremont Wellness Center, and the work we're doing on campus with our student health leaders. And I think it just goes to show you that, alhamdulillah, you're all going into a field in which you have a lot of extreme power and authority and your positionality, and it's really important to leverage that. And so Have some of you heard of the school to prison pipeline? You guys know what that is? And historically, areas where communities are being over-policed, right? For some of the smallest things, students as young as first, second, third grade, rather than going to the principal's office, are oftentimes arrested. And therefore, the name, the school to prison pipeline, came up. And so what we were able to do on the campus of Fremont High School, which our previous director of behavioral health, he just left us, he was actually a product of Fremont High School. The community rallied around him, paid for him to become an LCSW, and he was our director of behavioral health as well. And he came back in the community, and we started a program, a restorative justice and healing program on the campus of Fremont High School, making sure that when things happen, instead of calling the school resource officer and having that student arrested, we'd have restorative justice healing circles and working with students and they're, in a safe space to talk about what's happening. You can look up restorative justice practices if you're not familiar, and really breaking that school to prison pipeline. We were asked to testify at our local state assembly hearing in Sacramento about those practices and really breaking that pipeline down. But that came up because it was important collaboration with our physicians, with our behavioral health providers, and most importantly, with the community. There's definitely a growing services for our needs. So this is what on the left-hand side it looked like. Now the entire property is demolished. We are creating an additional 4th location, but right adjacent to this location is actually almost an acre of land, which is very hard to come by, in LA in general, specifically in South LA, where we'd like to build the first urgent care center in South Los Angeles, serving the entire community. Also, inshallah, an inpatient center. We have created our endowment after the first 25 years, a big push with the board, alhamdulillah. We've created a waqf for an endowment to take a national campaign to help establish many of these centers across the United States. So what Dr. Awad was saying kind of dovetails right into this. We understand the history of it, we understand the need of it, and we understand that we as American Muslims are best positioned to not only understand why it's necessary, but how do we actualize it in terms of the work that needs to get done on the ground. With elected officials, with banks, with financing, how does it happen? How do you put up a $50 million project? There's ways to do it, something called new market tax credits, right? That's where for-profit entities are given tax advantages to invest into underserved communities, right? That's oftentimes how hospitals are built and other institutions. We as American Muslims need to know how to leverage that and also build on our values to make sure that these values are being actualized in the community. So inshallah, a lot more coming. I do have some impact reports if you definitely want to check those out. And please take a look at the services we're doing. This is our first mobile clinic. It's a 2-room clinic with a bathroom. And this will be serving primarily the feeder schools, right? So we understand that John C. Fremont High School is just one high school. We've also partnered up with the local middle school and elementary schools of students and parents who will eventually come to Fremont to provide services to them on site, on location as well. So inshallah, we have another mobile clinic that's also in the works as well. And so when we talk about health equity, and I want to end with this slide, I know there's a lot of things that have been talked about, and I think the Federally Qualified Health Center model is uniquely positioned, not only in terms of being able to have the governance structure that dictates that patients are the primary focus of the healthcare that we deliver, and really creating a micro model of what we envision healthcare to look like in the United States. Yes, the system's broken, but what's the answer to fixing that system? There's folks who can push from the outside, and I think there are folks that can push from the inside. And I think federally qualified health centers are primarily focused to do that. And so how do we really think and look at health equity? I'll start from governance and management, right? Has to come from governance. I fundamentally believe, this is my personal opinion, and it's being recorded, not for-profit healthcare will be the demise of health equity in the United States. As long as we keep healthcare for shareholders in a model, that model is going to fail on its head because patients will never be prioritized. So until that governance and leadership and the management structure is not responsive to patient needs, that's not going to change. Workforce, again, what are we doing? We're building community. We are an economic engine, right? We're not doing charity care. We are building and empowering communities to take care of themselves, and we are furthering our values as a faith-based health institution, right? So recruitment, employee development, right? UMMA employees who are not Muslim are excited to come work. You know, on Friday, I took a red eye because we had our staff appreciation event. And I just wish I could bring the testimonials and how proud they feel to work for a Muslim organization. and how thankful they are to our donors and supporters for allowing UMMA to exist. But that also shows that we have the model to show what it means to treat employees respectfully, to take care of employees, to start college funds for employees' children, like things that we've done to help our workforce really feel welcome and a part of the community. Financial sustainability, right? This isn't charity, Ken. I think part of my dissertation work, and I think what I wanted to go study and understand was, growing up, I always saw volunteerism as a way to do good work when you had time, right? When you have time and when everything has been exhausted, and go to the food bank. Alhamdulillah, those are great things to do. But until we professionalize a community, our work into giving back to the community in the nonprofit sector, I think that's not going to happen. So it doesn't mean it's for everybody, but it's for some. And so really looking at financial sustainability for our nonprofits towards the systems of waqfs, ahqaf, and other things like that. But it has to be viable for it to happen. Most importantly, I think well positioned for FQHCs is population health and social determinants of health. We do a lot of work with the population health needs assessments in our community. We talked about the food insecurity work as well. The other psychosocial factors that impact communities' lives, and addressing those very, very effectively are really important for the federally qualified health centers. That does not mean, obviously, as part of that we leave out patient quality, patient care, and safety. So, alhamdulillah, I'm happy to say amongst 600 or 700 clinics, locations for other clinics in LA, we rank in the top 5% for most of our clinical measures. And that's because we prioritize quality in our care, patient experience, and access and affordability. So I think all of these can be addressed by federally qualified health centers. I know there's probably other things that you're thinking about, but in a way, if you are excited about any of this work and any of its facets, a federally qualified health center, either serving on the board of directors of one, or being part of one, or even working for one, I think is a viable career choice for you. And this work doesn't happen without local, national partners. I think what's really effectively allowed UMMA to grow and increase our organizational budget size, our staff, has been the ability to be small, but being responsive to the community's needs. So we're not just opening locations, we're really going upstream to look at some of the inequities that are being focused and working on. And at one time, UMMA actually had a residency training program prior to my time that went by the wayside. But actually now we're significantly interested in having first and second and sometimes third-year medical students rotate through us on early clinical experiences, and not just in the patient room. Many of the schools that we've partnered up with, and most recently this Kaiser School of Medicine that just opened a few years ago, are to have early clinical experiences. So one of the cohorts of the Kaiser medical students are working with our student health leaders. A few of them are taking on quality initiative programs and projects with our physicians. A few of them are looking at our food insecurity work as well. And that's just to think outside the box about the early experiences that you have in medical school. And if you have, the ability to advocate for yourselves and students to come behind you, ask your schools to see if they can partner up with local federally qualified health centers to gain some of this experience early on in your careers. Just reflecting as I end here, this is a quote with one of our other primary care, one of our consumer members shared. It's really impact and generational change. I mean, serving one family for that many generations, talking to my bosses who are patients of the community health center, being forefront and helping them to advocate for their own care is just a joy. I don't get up and I don't think that this is a job every day. I feel like I'm coming to the community that I live and work and serve in every single day. And I think as healthcare providers, as persons, inshallah, will have the financial means and inshallah career choices to look at, a federally qualified health center is a primary way that you can inshallah actualize your own Islamic values. Thank you so much. Assalamu alaikum.
Jazakallah khair. So in our community we have a free clinic that is Muslim run, and recently, alhamdulillah, a lot of the medical students have started volunteering there, but we've noticed that almost all of our logistic operations, I've been people of other faiths, and it's feeling like that the clinic is moving more away. Like most people come and they don't know that it was an Islamic clinic or started at the masjid or anything. How do you allow people to know that it's still like that there's still Islamic values that push this initiative forward, so that like you at least still get like a bit of dawah out to an extent?
Absolutely, and I think it's a critical point. You know, we have a standing board committee called the Islamic Identity Committee that's focused of even folks who are not Muslim who want to be part of that committee to help ensure the Islamic values of the institution are being actualized. But I think it goes back to maybe some feedback about the governance structure of the institution itself, right? So if there aren't formal bylaws or other things in place, one, to protect the organization because it's good nonprofit management practice in general. But I think as part of that, if it's founded by Muslims, those things can be put in there as well. So for example, UMMA as an organization does not deal with interest, right? That's just a fundamental practice that we have. So all of our financial practices do not touch interest. You know, certain things in terms of practices and, you know, staff parties, alcohol is always quite, you know, things like that get raised by, you know, staff members who are not Muslim who ask. So that's one. So I think you have to start at the top to make sure that that structure is created, because if you do it on certain small things, otherwise it seems a little disingenuous, right? So if people of other faith communities who might think, you know, you're just kind of imposing things. And to that end, actually, just a few years ago, we worked with a board consultant to think about why, to your question, why is UMMA an Islamic institution, right? Is it just the name? Is it just because I happen to be a CEO who's Muslim? We've had previous CEOs who are not Muslim, right? So what makes it so? And so what we did was we created a values document. Typically we would have, you know, excellence and other things that most nonprofit organizations have. But we took a step back and we actually derive values. And where's the best place to get that? The maqasid of the Sharia, the fundamental things that the Sharia has come to protect. So we outlined all those, we've written those out, and we shared it with our board members who are Muslim and non-Muslim and said, as an Islamic institution, these are the values that we believe in first and foremost. And here are some other secondary values, right? So you have to actualize at the top, have those discussions, and I think staff come to understand. And I joke, I said the other way they know that they're Muslim organizations, they have both Eid holiday off, so right? It's extra holidays for them. So they're excited about that. No, but it's the small things. We started, for example, doing like a brown paper bag lunch to talk about faith with our staff. Again, and not in a pushy way, and if folks want to feel comfortable about it, they're more than welcome to do so. During a lot of the shootings that unfortunately continue with Black and brown communities, we create town hall spaces to have a trauma-informed discussion, and often in trauma-informed discussions, there are talks about faith and spirituality, so we allow folks to express, share their comments, concerns. You know, we bring in, local scholars to talk about, and not in a way that I think more often allows them to learn something about Islam and its positionality on these topics, and then have them share their understanding as well. You guys all ready to work at a FQHC or be involved, inshallah? It's a great way to be involved in your communities. Yes.
Thank you for the work that you guys do. It's really inspiring as medical students to hear that this type of work is possible. And I was just curious if you could touch on how your clinic reaches the undocumented community and what type of work or what type of services are offered for them. Because I feel like that adds another obstacle when we're trying to reach underrepresented communities. And then the other part to that question was, what sort of barriers do you face when you're trying to plug your patients who are uninsured or unable to pay with subspecialty services such as like dermatology or surgery or more like specialized services, and the concern with like providing substandard care, but at the same time trying to provide a level of care?
Yeah, I think, I'll answer the second question, actually both questions kind of together. So in California, there's a big initiative right now. By 2024, the governor has put in the budget to make sure that all folks who are undocumented under the Medicaid program, we have, in LA County, we have something called My Health LA. It's a it's a different healthcare program that we get compensated for some basic care for undocumented community members. That program will be transitioning into everyone being able to be covered by Medicaid. So I think it's hard if you're in a non-expansive state in order to do that. But yeah, for substandard care, there is none. I think part of the way we partner with referral agencies as well, minus the big county hospitals that we work with, are to actually do site visits with them and ask our patients, where do you feel the most comfortable getting your care? And if their access is available and we can create a joint use understanding with an MOU and create things, then we refer them to there. We ask them, right? That's one area to do, is to ask patients where they'd like to go. And then to make sure that the quality of care being provided by the referral agencies is just up to standard. So it's really raising the level of expectations. I think that's another need why we'd like to open an urgent care. There is no entire South LA probably has community health centers probably serve roughly 750,000 patients just within South LA proper. There is not one urgent care facility. So everyone's going to hospitals, which is about 10 to 15 miles away, with public transportation and other needs. So we thought, as community health centers, and UMMA is taking the charge, why don't we create an urgent care for all of our patients that they can access 24 hours a day after hours, but still have their home clinics that they're individually assigned to. So I think, in a way, like I said, we're really literally building those health equity systems in the community we serve, because we know, it's too hard, and there's too many forces to push us on the outside in order to kind of go upstream, but it's really actualizing that as locally as possible.
إلا الله لا إله إلا الله لا إله إلا الله ما لنا